Yes, please start the slideshow. Yeah, it's moving.
It's moving. So I will repeat it again. So the case was of a 56-year-old lady who presented to our department with acute nephrotic syndrome and renal failure. Her history dates back to 2013 when she initially presented with multiple skin rash and gangrenes of the toe as seen in this image. And skin biopsy taken was suggestive of cryoglobulinic leukocytoclastic vasculitis. She had moderate non-oliguric renal failure at that time with a creatinine of 2.2. Searching for the etiology, she was diagnosed with bone marrow biopsy proven multiple myeloma. And she was treated for myeloma and complete resolution of symptoms was there and creatinine also normalized. And till 2022, she was on regular follow-up. In 2022, she again had a relapse of myeloma, this time with severe renal failure with a creatinine of 4.8. And cryoglobulin was negative at that time. And she was on conservative treatment of AKI and had treatment of myeloma. Following treatment of myeloma, again creatinine normalized. Renal biopsy was not done at that time. And they presumed AKI was due to the myeloma. At last, the latest creatinine was 1.21 in November 2024. So present admission was following a respiratory tract infection for which she took some indigenous medication, followed by presentation of an acute nephrotic syndrome as with hematuria, oliguria, and edema. She also had hypertension with blood pressure of 200 bar 100 millimeter of mercury and bilateral pitting pedal edema. So this was the image. She had an auto-amputated distal phalanx of fifth toe and necrotic heel ulceration over the left tibia. Investigation urine revealed albuminuria, hematuria, and sterile pyuria. Raised ESR of 83, urea of 165 with a proportionate increase of creatinine of 7.6, hyponatremia, decreased bicarbonate, hypocalcemia, hyperphosphatemia, and hyperuricemia. Since she had prior history of cryoglobulinic vasculitis, we did C3 and C4, which turned out to be normal. ANA was negative. PNCA, CNCA was negative. Serology for viral markers were also negative. Ultrasound done revealed normal size kidney with no evidence of any obstruction. Meanwhile, in hospital, she started to develop multiple ecchymosis at the injection sites. So to summarize, we had a 56-year-old lady with history of multiple myeloma presenting as cryoglobulic vasculitis, which was treated. And she also had episodes of non-dialysis requiring AKI, now presented with acute nephrotic syndrome with rapidly progressive renal failure. So differential, we considered the infection-related glomerular nephritis with acute kidney injury, since she had a prior history of a respiratory tract infection. We also consider acute tubular interstitial nephritis, since she gave history of Ayurvedic medication intake. And we also consider multiple myeloma, since she had the past history of the same. So since she presented with severe renal failure, she was managed with hemodialysis and was pulsed with methyl prednisolone. Once she became stable, we did a renal biopsy, which revealed membranoproliferative glomerulonephritis with extraglomerular vasculitis, intracapillary globules, and moderate acute and mild chronic tubular interstitial nephritis. So, to our surprise, it came down to be a cryoglobulin vasculitis, and which was also seen in the electron microscopy as mesangial and subendothelial electron dense deposits and occasional intracapillary thrombus. So we did a serum cryoglobulin, which turned out to be positive, and which we could also be elicited in our laboratory. As a workup of cryoglobulinemia, we also did HCV RNA PCR, which was negative. Next, to find the cause of cryoglobulinemia, we worked up for multiple myeloma, and immune electrophoresis revealed IgG kappa with a raised light chain ratio of 5 and an elevated beta 2 microglobulin. So here came the double trouble. That is, on one side we had cryoglobulinemia, and on the other side we had multiple myeloma. But we didn't have any active skin lesions. We had a normal C3 and C4. But in renal biopsy, there were only evidence of cryoglobulinemia as intracapillary globules and vasculitis. In case of multiple myeloma, electrophoresis was positive. Immunoelectrophoresis revealed IgG kappa. But in renal biopsy, there was no evidence of any myeloma. So our dilemma was, what is the cause of renal failure in present admission? As always in cryoglobulinemia, the primary dictum is to correct the primary cause of cryoglobulic vasculitis. Here, the patient had multiple myeloma, but it was not seen in renal biopsy to attribute it as the cause of renal failure in our patient. So we consulted with the oncologist who told to treat first the cryoglobulinar vasculitis, stabilize the patient, and then treat for multiple myeloma. So we also did a plasma exchange along with hemodialysis and steroids. Surprisingly, she had both clinical and biochemical remission by increasing urine volume, improving of creatinine to 1.9, and resolution of symptoms, ecchymosis. And she was discharged on prednisolone and azathioprine. 1 week later, she was started on multiple myeloma therapy, and she refused autologous stem cell transplantation. On follow-up, she had a creatinine of 1.5 with urine output more than 2 liters. So final diagnosis is type 1 cryoglobulic glomerulonephritis and multiple myeloma relapse. So why we presented this case is multiple myeloma presenting as cryoglobulinic vasculitis is very rare. So there are only 3 case reports that reveal type 1 cryoglobulinemia with multiple myeloma, which required dialysis. Another rarity was it's usually the leukocytoclastic vasculitis, which is seen more in type 2 cryoglobulinemia. But our patient had type 1 cryoglobulinemia presenting as leukocytoclastic vasculitis. It is usually the non-inflammatory thrombotic lesions that are more common in type 1 cryoglobulinemia. And C3 and C4 may remain within normal range as in our case, if it is not actively causing any significant complement activation. Although addressing the primary causes is the treatment of cryoglobulic vasculitis, our patient had recovery of renal failure by treatment of vasculitis alone. As always, renal biopsy provides the ultimate diagnostic clarity whenever the cause is uncertain. Before I conclude, I would also like to thank Ren